Hey, everybody. Welcome to the Dementia Rosary podcast. My name is Matt Estrad. I am a gerontologist, and I work with busy Catholic families who are impacted by Alzheimer's disease and other types of dementia. Today, I am so pleased to be here with our special guest, Dr. Landon Roussel. Let me tell you a little bit about him. He is the sole owner and physician at Communitas Primary Care, a direct primary care clinic in Baton Rouge, Louisiana. He is board certified in internal medicine with extensive experience in primary care, geriatrics, and house calls, having completed over 1,000 house calls as a doctor in Southeast Louisiana. And I hope we're going to hear about those in this interview. Prior to coming to Baton Rouge, he trained as an intern and resident in internal medicine, specializing in primary care through Harvard Medical School at the Mount Auburn Hospital in Cambridge, Massachusetts. There, he also was a clinical fellow in medicine at Harvard Medical School. He earned his doctorate in medicine at Cornell Medical College in New York City, a master's degree in bioethics, summa cum laude, through the Erasmus Mundus program at the universities of, and there's three of them, Leuven in Belgium, Rabaud in the Netherlands, and Padova in Italy. And I hope I pronounced those correctly. And his bachelor degrees, magna cum laude, in both biochemistry and Hispanic studies from Rice University in Houston, Texas. He's also the host of the Direct Primary Care podcast that you can find on iTunes and all of the different podcast platforms. And we're going to link to his website and to all of these resources in the show notes. So Dr. Landon, welcome to the Peace with Dementia Rosary podcast.
Great to join you. Glad to be here.
So before we get into dementia, your thoughts on that and your experiences, I mentioned some terms in your biography that most people are probably not familiar with, and that's direct primary care. Can you tell us about that model of medicine that you practice?
Yeah, so direct primary care is basically primary care that goes directly to the patients and minimizes unnecessary or intervention from outside influences, be that the insurance company or, government, whatever. So the idea is that we charge patients directly for primary care as opposed to purely relying on insurance to provide primary care, which allows us a lot more flexibility than having to comply with the, in my opinion, overly onerous requirements of insurance companies and the government. The model for primary care, unfortunately, is a broken model, and it relies on basically doing more things to pay your bills, and that's not always what people need. Doing more things, oftentimes people need more relationship, more time, more just attention that doesn't necessarily have to result in medical intervention. But unfortunately, the way the system works, it pays for intervention. So direct primary care cuts all that out, makes it easy, and just goes directly to the patients and says, hey, we'll charge you what we think is a fair price for primary care services, typically as a membership model. So that's how I've been doing it for coming on 6 years now. And I couldn't do healthcare any other way.
And if people are interested, so not everybody is in your area and able to go to your practice. If someone's interested in the direct primary care model for themselves and their family, what's the best way to find a provider in their area?
Yeah, you can go to dpcfrontier.com. That's dpcfrontier.com/mapper. And it will give you a map of all the DPC practices in the area. Some areas, unfortunately, are slim pickings, I have to say, and some people may not have ready access. I mean, we've had a hard time finding a doctor who isn't me for my family here in Baton Rouge. Mm-hmm. And it's unfortunate, but that's because it really is kind of a off the beaten path model, and you can't rely on insurance companies to pay your bill when you're when you have a DPC practice. And so you have to rely on patients paying you, which is a for most healthcare personnel, doctors, they're very averse to uncertainty. So it's a different model, and it takes work to for docs to make it work, but it is so gratifying to not have to worry about all that silliness of, whether I have to document this level or that level or this to be able to get paid, and then just, having that interfere with the doctor-patient relationship. That's it's a very gratifying way to provide healthcare.
And since this is the Peace with Dementia Rosary podcast, I should mention that you're a Catholic. You're in the Knights of Columbus, 4th degree. And can you tell us more about your background? I think you've done some missions.
Columbus right there. There's my bioethics degrees right there. Let's see, that one is Leuven in Padua, and that one is Radboud in the Netherlands.
Oh, great.
Yeah. Anyways.
Yeah. So can you tell us more about your faith and things that you've done? I may have seen some mission work as well in your biography.
Yes, prior to medical school, I did some work in Guatemala, actually vaccinating people for measles. But yeah, I mean, my sort of decision to start direct primary care practice was deeply affected by my faith. And I've spoken about this before, but Pope, I believe it was John the 23rd, correct me if I'm wrong, Rerum Novarum encyclical, and the idea of the economy being underpinned by a faith economy, and of promotion of human dignity and economic life, and the idea that that needs of people and dignity of persons is best satisfied through minimal intervention by larger entities. And so when that comes to healthcare, I think that right now we've reached a situation where the dignity of doctors and patients is under stress, and it's under unnecessary stress because of undue intervention by larger bodies, whether it's massive insurance company conglomerates, whether it's governmental regulation, or whether it's increasingly consolidating hospital administration or hospitals that in my opinion are putting strain on the sacredness of that doctor-patient relationship. And for me, the only way that I feel like I can do right by my patients is through this direct care model.
Let's start in primary care with dementia management. My understanding is that the majority of cases of dementia, like countrywide or worldwide, they're caught in primary care. Or at least they can be caught, and they're before being referred to neurology or neuropsychology. What advice do you have for patients as far as should they start with their primary care physician if they start to see some signs? And what are those signs that you recommend that people make that appointment with primary care sooner than later?
I'll go one further with you, but before I answer that question, is that oftentimes the primary care doctor is the only one who manages the dementia. That's it for the entire course of the disease. And so it's very important, I think, that the patient gets the primary care doctor involved, or that they approach their primary care doctor with those concerns. Typically, when people start having early symptoms, it's forgetting simple things, forgetting where you put the keys, forgetting, and not just like a one-time thing, but I don't remember what I ate for breakfast this morning, type of thing. Mm-hmm. Sometimes it's feeling them finding themselves disoriented, like, well, Dad took a walk and I can't find him, and he's in the park down the street and doesn't know where he is. Mm-hmm. That kind of thing. The thing that first goes is short-term memory with the disease, because it affects a part of the brain called the hippocampus. That's typically where it starts. And the hippocampus is involved in short-term memory making. And so you'll see, mom or dad or aunt or uncle, they can't remember, what happened yesterday, or but they can remember 50 years ago, because long-term memory is not necessarily in the hippocampus. So they start losing their short-term memory. That's the first thing. And so I do encourage people when they start doing that to go over it with their primary care physician. And actually now Medicare, which we still, even if you're a DPC doctor, you have to interact with Medicare. It's just the federal system that we have. Medicare now pays for cognitive testing by primary care physicians. And so we can do primary cognitive testing, but it's definitely worth checking in the core, either as a part of a routine annual exam or as part of a specific cognitive testing visit to one, to make sure there's no other causes of dementia that could be addressed, whether it's related to B12 deficiency, which is a common cause. Vitamin B12 deficiency in elderly can look like Alzheimer's when it's just reality that people aren't getting enough B12. Or whether it's impairment of thyroid function because their thyroid is low and they just don't realize it, or whether it's from chronic strokes, which in Louisiana, we're in the stroke belt. So we see a lot of people with chronic strokes that mimics Alzheimer's types dementia, and that could be treated with medicines to prevent recurrence of stroke or detection of irregular heart rate that can increase the risk of stroke. Whatever the case, that can be done by a primary care doctor, by the way. It doesn't have to be done by a neurologist. So there's treatment implications. That's number one of catching early cognitive impairment. But then number two is to make sure that people have plan in place for what happens if they do have Alzheimer's dementia, because we do know it is a terminal condition, but it's not like terminal like die tomorrow. It's usually like terminal like 5 to 10 years, this kind of thing. And unfortunately, right now, we don't have any treatment that halts the disease. I'm hopeful that we will, and I think we will if you wait 50 years. But whatever the case, we don't have any treatment that halts the disease. So we have to, I think a person who gets that early diagnosis is best served by knowing that, so that they can start making plans to make sure that you have caregivers in place, so that what's going to happen. Are you going to have a caregiver who stays with you when you start having dependence in your activities of daily living? Or are you going to go into an assisted living memory care unit? Or are you going to go into a nursing home? And even if you have, that plan, who's going to be the family member who's going to make medical decisions for you when you have trouble doing that? You need to think about that, because honestly, you're going to be in a much better place if you've planned for that than if you haven't. I am not one for excessively planning life, but appropriately planning life. And I think that's appropriate. And unfortunately, we live in a world where we fear death, and we fear disability, and we fear debility, and we fear dementia, because, it just reminds us of our own mortality. And then that fear leads us to avoidance. And then the avoidance leads us to, neglecting things that we could have done to make our lives better. So don't be avoidant. I struggle. I'm preaching to myself, by the way.
No, this is great, succinct advice that we all need to be reminded that, because it is difficult, because it is ambiguous, because we don't want to hear the diagnosis. We tend to avoid it.
It's funny. Sad, actually. I remember I had an aunt, my great aunt. She got dementia, and it progressed pretty fast. I think it's my only family member I've seen got dementia, but it started around age 90, which is very common. Age 90, more than 50% of the population has it. It's just like, people don't understand as well, because you see wrinkles on the outside of your body. Your skin doesn't live forever. Your skin wrinkles, but it's the same thing in the brain. Your brain doesn't live forever. Your brain wrinkles too. It's basically brain wrinkles. In any case, she got dementia, and I remember visiting her a couple of times, and then she got a stroke. And I remember she was on hospice, and on her last days, there was nobody there. She just, I think it's hard for some people to see their own family member sick and getting debilitated, and sometimes that reminder of our own mortality pushes us to try to stay away from that or to avoid it. Anyways.
Can you talk about where our Catholic faith intersects with suffering that we could, that you see, I'm sure, on a daily basis, and even go into dementia if appropriate. So where our faith and suffering and dementia may intersect. Thoughts that you have on that?
Yeah, absolutely. Well, we didn't have this understanding of the condition dementia when in biblical times, to be able to have Jesus say, go sit with your elderly demented family members and be with them. But I think he would have if he.
Yeah.
But in any case, we do have in James chapter 2, where we hear the early believers in the talking about the responsibility to the sick and the orphaned and the widows, and we know that Jesus, his mission was a healing mission, and it was being with the sick and being with the frail, and being with the lepers. And so I think as Catholics, we have a responsibility, and this is in the catechism, but a responsibility to help those who are suffering, and help those with medical illnesses, and dementia is foremost among one of the top ones that affects the world. And as we have medical technology to keep people alive for longer, less people are dying of heart attacks, less people are dying of common things that people died of in the past, strokes. We're keeping people alive longer so that they live with dementia. It's becoming this condition that its prevalence is increasing throughout the world, and so we're going to have to grapple with that. But I think, and I've taken care of a lot of people with dementia, and I've sat with them in their homes and counseled their families on how to deal with it and how to best care for them. I think everyone can benefit from family members spending more time with their loved one with dementia. The one who has dementia benefits from that social stimulation. It actually can cause brain plasticity. It can cause their brain to actually develop new connections, that social connection with their family. And then I think from the perspective of the family member who has a healthy brain or who doesn't have dementia, there's that benefit of relationship, and there's that benefit of connection to the past, to your family. And they've done studies to show that children who are around elderly family members who are on hospice have less discomfort with their own mortality, and are able to have less anxiety over their own mortality, because they see that just this dying is part of life. Mm-hmm. And that you're not going to be able to avoid it. Sort of like the Lion King, I guess.
Yeah. You mentioned that word hospice, and that's a word that strikes fear into the hearts of many people. Can you talk about what hospice is? When do you typically refer someone? Like, what sort of signs do you have? And specifically with dementia, what sort of signs are you looking for before you do that? And then also, what's the broader term palliative care, and how does that fit in with dementia?
Talk about that, but before I answer that, let me just show you a little picture I just drew. This is our current model of how we manage most people on hospice with terminal conditions. We give them aggressive medical care until X point, and then we say, up, they're hospice eligible, and then we stop everything, and the hospice companies come in out of the woodwork and just stop everything, and that's it. And that's why people are afraid of hospice, because it's like, this, you might as well just say this is the what do you call it, the Grim Reaper coming in. That's how most people see it, as the Grim Reaper. You stopped your medical care, now the Grim Reaper's here. And that shouldn't be the case. That should not be the case. What we need to do to be able to address this issue of death as a process, because death is a process. It's not usually, some people die suddenly, but most people these days, chances are you're going to live to see, to die of a chronic condition that is terminal. That's most people. It should be more like a gradation, to where you kind of decide what point you're going to stop doing different levels of medical care. And the hospice point is the point at which you pretty much is where you stop going to the hospital. That's the sort of line. But more holistically, it's where you've accepted that your condition is terminal, or that the condition of your loved one is not going to get better, and that you want to at least focus on comfort over prolongation of life. That's the big picture. Practically speaking, hospice has been a covered benefit of Medicare for some decades now, since the 70s, maybe 80s. I think since the 1980s. And it involves the provision of comprehensive care for the dying patient who has been deemed to be terminal, and terminal is considered a 6-month reasonable life expectancy. When it comes to dementia, that means that usually, if it's just dementia, usually it's when they start losing their mobility and ability to swallow. That's kind of when I consider them hospice eligible. Although some people with dementia have other conditions that could qualify them. Anyways, the comprehensive care usually involves nursing support that is overseen by a physician. It involves things like hospital bed, oxygen, medications. It involves a chaplain. It involves and you know what's sad? We have a hard time getting Catholic chaplains, Catholic priests for sure. We just can't get those. They're so busy. Those priests are so busy. We don't have many priests as Catholic chaplains because they're just busy. They're also, there's not that many. There's just not a long, so there's a little bit of a shortage, you could say, just like primary care doctors, there's a little bit of a shortage of Catholic priests to do that. But in any case, it's a comprehensive service. I usually recommend family members get hospice involved sooner rather than later for dementia, because they end up being much more satisfied in the process. And even there's studies that are coming out that show that people live longer on hospice than off hospice with certain conditions. And I think dementia is one of those, because they get a lot more support is one. They get a lot more care to provide for their whole needs, as opposed to this episodic care that comes from frequent hospital visits and frequent emergency room visits, and going to this whole Rolodeck of specialists.
Any practical tips on choosing a hospice company? Because I understand they have salespeople and marketers just like every other company, and they come in, and sometimes it can be high pressure, sometimes it's more educational, but
dirty business. I usually say go to your doctor and say who do you work with, because what a lot of people don't want to see is they don't want to see, oh, now I'm on hospice, now everything stops, and I'm just sort of, and I've seen, unfortunately, some agencies, they just kind of give them a bed and give them some medicines and say, call us when you need us, which is not the way to do things. But whatever the case, you want that care process to be a continuum. And so ideally the doctor, nothing should change. The doctor should still be overseeing the care with, so oftentimes that's where I would say go with the doctor. I just put somebody on hospice yesterday, who had melanoma, fortunately younger in the scheme of things. And I mean, I'm the director of a hospice agency, but I said, look, you should go with and I spoke to the cancer doctor. I said, look, you need to go where that cancer doctor wants you to go with, or who that cancer doctor can work with, because that's someone who's been taking care of you through this whole cancer journey. And so, they'll understand the nature of your terminal condition and be able to treat that the best. So I think that continuing that doctor-patient relationship is very important. Certainly you can look on Google reviews of hospice agencies if you want to get a sense of which one might be worth going with or which one isn't. That's not unreasonable. And then you can look at patient experience. The Google reviews will tell you. Google doesn't lie.
Mm-hmm. I have one more question for you, and then I'm going to let you talk about if there's anything that I didn't get to ask you that you get an opportunity to talk about while we have our audience of caregivers, but also persons living with dementia and professionals. So can you talk about what deprescribing is and what should patients do with the information that you share with us today?
That's a good continuation of the discussion on hospice. I haven't heard it termed that way, deprescribing, but let's say this: polypharmacy is a huge problem in this country for elderly people, and people with dementia it's probably even worse because they have somebody else doing their medicines for them, oftentimes, not always, but oftentimes. Mm-hmm. Usually when you get above 10 medicines, which is a lot of people, the incidence of adverse effects just goes, it's not additive, it's exponential. So, and even 5 medicines or more, they've shown that the incidence of adverse effects goes up. Medication interactions, just the additive effect of multiple medicines. Some people need that. I mean, I have one patient who's on 15 or 20 medicines, and I've tried so many times to take her off the medicines, and it never works. Mm-hmm. But anyways, I find most patients with any medical condition, but certainly with dementia, are best served by minimizing the amount of medicines to what is essential for them. And that is best done by a solid doctor-patient relationship and by time that doctor has to address those issues and to see which medicines are really essential. Mm-hmm. And some people some patients I have to work to explain to them why they don't need to be on so many medicines. But a lot of my patients, I can say they appreciate that I'm honest with them, and I won't try to shove medicine down their throats. I'll tell you if I think you need to be honest on it. That is kind of I feel like sometimes I'm fighting an uphill battle, or I'm trying to kayak. I'm an outdoors person. I'm trying to kayak against the current with that, because it's just like when people get on Medicare, it's like the moment you enroll on Medicare, they start you on medicines, and then you start your number of doctors you see multiplies by 5 to 10 once you get on Medicare, because hey, the government pays for it. So I find myself continually having to fight to do that. But I'm a doctor of the whole person, and I've got a lot of experience, both from an intellectual side and then also just practical side, caring for multiple medical conditions. So I usually, if I have a patient that is a member of the practice, and we have that space where I can care for them as a DPC patient or as a membership patient, whatever you want to call them, we can do a good job of getting them down to the essentials. But it is a huge issue. Polypharmacy people get on medicines, they get medication adverse events, they get hospitalized for different, and it's hard under our current system because honestly, the current system pays more the more things that are done and the more things that are happened. So
Mhm.
you give somebody 10 medicines and then they get delirious, and then they vomit and they aspirate and they get pneumonia. That's all more bills and more procedures that you can do. So technically the system pays for getting sicker, which is sad. It's a sick-based
Mhm.
system. But that's not what people want. People want to be healthy. And so that's what membership allows, was for me to focus more on overall what people want as opposed to what the system pays for.
Yeah, excellent. Thanks for the explanation. So you have the floor. Is there anything that you want to talk about that I didn't get to ask about, whether it's faith, whether it's about dementia, primary care?
Yeah, I mean, this podcast, as you've told me, is for people with either caregivers of people with dementia or even people with dementia themselves. And it's a tough condition to see somebody go through, but I think there can be a lot of joy there. You just can't be as who was it? Was it Mark Twain who said, if you're going to eat a frog, eat it first thing in the morning? You
Right.
you you can't avoid it. You can't. It's gonna hit you in the face someday if you do, and it might be pretty hard. So, your best, you're gonna be in a much better place if you start addressing those things now, planning for that, for the disease now, as opposed to later. Um, I am hopeful about potential treatment around the corner that could prevent the progression of disease. There has been an IV medicine that was approved, and it hasn't had good data, unfortunately.
Right. Yeah.
Um, but I am hopeful about that. But we're not there yet. And either way, even if we find a cure for dementia, our bodies are still finite. We haven't found the fountain of youth, and I
Right.
don't think we will. So we'll die from something else. But in any case, right now it's not a curable condition. So we've got a plan for where we are right now.
Well said. That is a great place to end. Dr. Landon, thank you so much for joining us and speaking to my audience here on the Peace with Dementia Rosary podcast. Um, we're
Absolutely.
gonna we're gonna
I
have
can say
links
one
to.
thing is, if
Okay.
people want to find me,
Yeah.
uh, Communitas Primary Care, that's my website. And we've got a good thing, we got a good practice going right now, and we do a good job for our patients with dementia, particularly who are homebound. So if people are interested, they can call our practice, and we serve people quite extensively in the Southeast Louisiana area. So we've got a good reach. Patients in New Orleans, patients in Acadiana,
Hmm.
patients in Baton Rouge, Ascension, St. James, St. John, all those parishes.
That's a
So,
big footprint.
yep. So, anyways, well, good to talk to you.
Yeah, same here. Same here. Thank you for your vocation. God bless you and your work and your family. And I hope we get to speak again in the future.
Absolutely. You take care and stay safe.
All right. Thanks. You too. Bye bye.